Hey, nice to meet everyone today. First off, I'd like to thank Dr. Grant, as well as the ASAP organizers for allowing me to speak today. It's quite a privilege to be amongst all these other people who are, from my perspective, much more experienced than I am as a neurosurgeon. So as mentioned, I am a assistant professor at Duke and a neurosurgeon who is very interested in things like intracranial pressure and trying to understand a little bit more about how intracranial pressure works and how it links up to many of the disorders that we see that are involved with changes in intracranial pressure, like Chiari malformations. All right. Oh, there we go. All right, I have no conflicts of interest to declare. So just to give an outline of the talk, I'm going to be talking a little bit about, as Dr. Grant mentioned, kind of the opposite end of the spectrum from CSF leaks, and that's idiopathic intracranial hypertension. The term idiopathic, I guess, is, again, another term that we use because the truth is that we don't really understand the pathophysiology of this disorder. And so we call it idiopathic, and I think that's just because at some point, hopefully in the future, we'll understand a little bit more about how it works and why patients actually develop this. And so I'm going to go through the clinical symptoms, which, as you've heard many, many times today, actually overlap substantially with CSF leaks and with Chiari's. And then I'm going to talk about some of the radiographical measurements that one can do if one's concerned about a patient coming into clinic that has a Chiari. The question becomes, well, is it a primary Chiari or could this be potentially an acquired Chiari? And I'm going to briefly talk about some of the neuro-ophthalmological findings of IAH because that's actually critical to the diagnosis and as well as the treatment. And also just briefly touch upon, when these patients would potentially benefit from intracranial pressure measurements. And then I'm going to talk a little bit about IAH since people might not be as familiar with the disorder, talk about the diagnostic criteria, and then current treatments as well as many clinical trials that are currently ongoing. And hopefully one that we will be starting here at Duke soon. So a lot of patients come into clinic with Chiari's, and over the course of the past year, I've had many patients come into my clinic. And one thing that I always ask when I see these patients is, okay, are the symptoms classical for what we would expect for a Chiari, and could this be a result of a secondary cause? And so the two kind of main things that are going through one's mind is, does a patient potentially have a CSF leak? And, Dr. Gray had talked about some of the things to look for in that particular situation. And the other thing is, well, could this potentially be an acquired Chiari? And does the patient actually have high intracranial pressure? And as a result, has developed the Chiari as a result of the high intracranial pressure instead? And so the reason this question is so critical is because we don't want to operate on people who are not going to respond and who are not going to do well. And there is evidence that patients who actually primarily have IAH, when we do posterior decompressions on these patients, they actually do not do any better. Some patients actually will temporarily improve, but then over the course of a year to 2 years, they'll kind of revert back to right where they were before the surgery. And so just to go through a couple of studies that show the relationship between IAH and Chiari's, if you actually look at a group of IAH patients, you'll find that they all have lower tonsils than you would expect in the general population. Approximately, and these numbers are going to be, pretty variable depending on the study. But other studies have shown that it's 8 times more common than compared to the general population for patients who come in with IH to actually have Chiari malformations. And there was a study that was done that actually found that approximately 42% of patients were actually found to have what originally was most likely an acquired Chiari malformation. And those patients, after getting posterior decompressions, actually ended up getting shunts and doing better as a result of the shunting. And so the important question is, you have a patient in clinic and you're wondering, okay, does this patient have high intracranial pressures? And potentially, is this an acquired tonsillar ectopia? And at this point, it would be important also to mention that there is some evidence in the literature and there are some case reports that the opposite is true. So it's kind of a chicken and egg problem. Some people think there's a couple of literature reports that suggest that the Chiari malformation itself can actually lead to high intracranial pressures. And the thought is that sometimes with descent of the tonsils. You can also get potentially venous congestion in that area that elevates the intracranial pressure. So there's a couple reports of that as well. So it's difficult because sometimes it's very hard to figure out what is cause and what's effect. So just going through the basic criteria for IH, there's kind of two different criteria that are used. Most commonly, the Friedman criteria and the modified Dandy criteria. And most of the time, the kind of classic thing that one sees with IH is papilledema. And so all patients, if we are concerned about potentially high pressures, should be evaluated for papilledema because that's a core part of the actual diagnosis. Now, it is important to mention that even with a diagnosis of papilledema, you can kind of go down that road and say, okay, the patient must have, elevated pressures because most of the time papilledema will result from elevated pressures. But there's also that kind of borderline range where we're looking at patients who are somewhere between 20 centimeters of water and 30 centimeters of water, and those patients may not necessarily develop papilledema. So there is a secondary category of patients, and this is termed IH without papilledema. These would probably represent about 5% of all this patient population. And so on top of the typical clinical findings, there would have to be some radiographic findings as well, and I'm going to actually go through all those kind of radiographic findings a little bit later. So to start from the basic description of headaches, this is the most common presentation for a patient with IH. Almost all IH patients will have some degree of headaches. So how do we differentiate a Chiari headache from an IH or high pressure headache? And the answer is that it's very difficult. But there are certain things that are more classic of, tonsillar ectopia type headaches versus headaches that are a result of high intracranial pressure. And so one of those things that's a classic Chiari headache is going to be occipital. A lot of patients with IH will actually present with temporal or frontal headaches. And it can be quite variable. Generally, it's going to be bilateral. It's going to be more generalized. And sometimes patients also complain of headaches behind the eyes. They'll describe the headaches with high pressure. The headaches will often be described as pulsating or throbbing, which is somewhat similar, but a little bit different to the typical Chiari headache. And then in terms of positionality, actually, they will be quite similar in that both headaches will actually worsen when the patient's bending over. Another thing that's important is that both headaches will actually be provoked by cough and Valsalva maneuvers, because you can imagine that any maneuver that increases intracranial pressure is going to result in worsening of that headache. So looking at some of the other symptoms, how do they overlap? So dizziness and vertigo, probably more common with tonsillar ectopia and Chiari versus with IH. Pulsatile tinnitus, definitely more common in the IH population. And then visual disturbances are very common in the IH population, but can also occur in the Chiari population as well. One of the kind of classic symptoms for patients with high intracranial pressure is something called a TVO, which is a transient visual obscuration. And what that is, it's kind of like a black curtain that comes down over the eyes. And oftentimes that's provoked by maneuvers, which again, increase intracranial pressure. So bending forward, coughing, sneezing, laughing, all these things tend to provoke TVOs. Another thing that one can look at is demographics. So majority of IH patients are going to have a higher than normal BMI. They're going to be younger and they're going to be female. Majority, 95% of these patients are female. The extent of tonsillar herniation, as previously shown in the literature, is slightly less than one would expect with a primary Chiari. And the other kind of signs, and I'm going to go through the radiological signs in a little bit, one of them is transverse sinus stenosis. And since the first kind of stent was done for this, and I think that was back in the late 90s, 94, now that's actually becoming one of the kind of main ways that we can actually treat this disorder. So I'm going to talk a little bit about that and the clinical trials that are ongoing for that as well. So again, whenever a patient comes into clinic and you're thinking about all these different kind of diagnoses, it is important to also think about what could be secondary. And so we spent a lot of time today talking about, different kinds of things like metabolic and endocrine things that can be oftentimes associated with some of these entities. So the first thing is to look at a medication list and say, okay, well, what medications is the patient on? Could these medications be contributing to high intracranial pressure? So some of the most common medications are shown on the left. Things like lithium are kind of known contributors. Things like tetracycline, hypervitaminosis has been known for a long time. Even some antibiotics. and even some oral contraceptives. In fact, the levonorgestrel IUD in some series also has been associated with the development of IH. Other things that it's really important to rule out, so things like anemia. Anemia, and we don't understand the mechanism again, can actually strongly provoke IH. And so sometimes once in a while we'll get a patient who's anemic, we actually give them a blood transfusion and they improve. And so there's a whole bunch of entities, metabolic and endocrine, and I think we've actually talked about a few of those today. And then also the syndromic ones, which are kind of less common, but it's possible you can get an adult patient. So I see only adult patients, and sometimes adult patients will come into the clinic and they may not be diagnosed with some syndromic entity. And so it's something to think about. So again, in trying to figure out, is this a primary Chiari or could this be a result of high intracranial pressures? There's a couple of different things that we can look at on MRIs to try to differentiate these two entities. So kind of one of the most common things is looking at a partially empty cell, and this is easy to do because typically when we're looking for a Chiari malformation, we're going to be looking at the sagittal MRI, T1 or T2. We're looking at CSF, and we're looking to see descent of the tonsils. And so in that same cut, you can actually just look right at the hypophysis, see how much space there is, and see whether or not the patient has either a partially empty cella or an empty cella. Another sign that is pretty common is a tortuous optic nerve, and you can see that on the right side. So the top figure is normal, and then you can see down here, you have a little bit of tortuosity with the optic nerve here. And so that's common in high-pressure syndromes. Something else that's actually quite common is posterior globe flattening, and again, this is a little bit more subjective and is hard to see, but here you can see a little bit the posterior part of the globe is more flattened than normal. And you can actually see the optic nerve head is protruding a little bit into the globe here, and that's another potential sign of high pressures. Another one is looking for a dilated optic nerve sheath. So for example, this is a normal example here. And if you look here, and you can actually measure this, so if you go 3 millimeters back from the posterior part of the globe, and you measure that distance, if that distance is greater than 5.3 millimeters in general, then that would suggest that potentially there's a dilated optic nerve sheath. Slit-like ventricles are very common in patients with IH, but again, not super sensitive and specific. Something to remember that a lot of these signs, again, are not very sensitive and specific. Transverse venous sinus stenosis, though, is one of those things that actually is pretty rare in the general population. So we're talking about something like 3%. But if we're looking at IH patients, it's about 60%. So there's a huge difference between what we see in IH patients versus the general population. And so typically with transverse sinus stenosis, what you see is that the stenosis will occur at the junction of the sigmoid and the transverse sinus. And it only becomes relevant if, for example, the patient has bilateral stenosis, or alternatively, if there's a hypoplastic sinus on one side and the dominant side is stenotic. And so in that situation, you would worry that potentially the patient might have higher intracranial pressures as a result of that stenosis. So again, it's important to kind of figure out, okay, when we see these signs, it's like when we see a Chiari, like, is this something that we need to do something about, or is this just an incidental finding? And so it's always important to kind of compare it to what you see in the general population. So for example, something like an empty cella actually is pretty common in the general population. If you just take a bunch of patients and look at them, you take 100 patients, 30 of those patients may actually have an empty cella or a partially empty cella. So it's not necessarily a sign that you can say, okay, I see this, I think the patient might have high intracranial pressure. The other signs are a little bit more sensitive and specific. So the dilated optic nerve sheath, you're going to see in about 60% of patients. Posterior globe flattening, probably 25%. Transverse venous sinus stenosis, again, about 60%. Again, these numbers do vary. There's articles out there that suggest it might be up to 90%. In my personal experience, that's not the case. Tortuous optic nerve, about half of patients might have that. And so if you look at the proportion in the general population, it's significantly less. So having multiple of these signs, for example, having 3 of these signs would really point you to think that, okay, this patient might actually have high intracranial pressures. And so one of the most critical parts of determining whether or not this is the case is the neuro-ophthalmological examination. And so the biggest thing that we look for is papilledema. And it's important to note that a lot of people say, the papilledema needs to be bilateral. Not necessarily, actually. We do see unilateral papilledema actually in a lot of patients that have high intracranial pressures. But this is just an example of how we grade them. But we're basically looking at the optic nerve and seeing whether or not there's swelling at the level of the optic nerve. Two other things that we look for specifically in IH patients. So visual fields are pretty important. A lot of these patients will have restriction of their visual fields, and sometimes they won't be able to tell that themselves subjectively, and so you need to actually do this testing to determine whether or not that's the case. So this is common. Arcuate defects are common, and nasal steps, as is shown here. The other thing that may not be available in all in all centers is OCT, and what this is it's called spectral domain optical coherence tomography. And what this is it actually takes a picture of various layers at the back of the eye. And you can see here, for example, that this is a patient that has significant swelling around the optic nerve head. And this is an example of a normal, and this is an example of somebody who has pretty profound papilledema. Now, the only caveat to that is that when the optic nerve head starts to die, this will also get thinner. So when you see that these layers are getting smaller, it won't necessarily always mean that the pressure is coming down. It could actually mean that the optic nerve is dying, and so that's one caveat to interpreting some of these studies. Okay, so you have a patient who, comes in, has a Chiari, and you're wondering, okay, is this secondary to IH? And you see a couple of these signs and you think, okay, maybe this is potentially secondary to IH. So critical parts of evaluating these patients, you want to do an MRV to rule out sinus stenosis. And when you do that MRV, you also want to take a look at the neck, because the stenosis can happen further down as well. It doesn't necessarily have to happen at the level of the transverse sinus. So for example, there's a lot of patients that have jugular vein stenosis, and that also potentially can cause an increase in intracranial pressures. These patients should be assessed by a neuro-ophthalmologist, preferably neuro-ophtho, and somebody who deals with IH patients frequently, because again, there is a level of subjectivity to the interpretation of some of the neuro-ophthalmological findings. And then lumbar puncture, and we kind of talked about this a little bit yesterday. So lumbar puncture will give us a opening pressure at a single point in time. It has to be done properly in the lateral decubitus position in order to get an accurate result. In general, for patients who do have tonsillar ectopia, it's considered to be a relative contraindication, but not a absolute contraindication. And this is due to the history of doing LPs. Now we use, again, smaller needles, so that makes a huge difference. Dr. Grade mentioned the digital manometer as well, where we don't have to take out as much fluid. You can just get the opening pressure and that's it. So in general, it's pretty safe. So even if a patient does come in and there's a fair amount of foramen magnum crowding, and there's a significant Chiari, you can still feel fairly comfortable getting a lumbar puncture and getting an opening pressure. So how do we treat this entity? And this is an important question because of the fact that doing a posterior fossa decompression is a fairly it's not a trivial surgery. And so if the Chiari is due to something like IH and we can treat that with medication, I mean that makes a huge difference to patients. We don't have to go down the surgical route. And so the first thing that we do typically is treat with a medication called Diamox or acetazolamide. And I'm actually going to show in a little bit of slide which shows how these drugs actually work. But acetazolamide or Diamox basically has the most evidence behind it, and it is a medication that reduces the production of the cerebrospinal fluid. Methazolamide is similar, fewer side effects, slightly weaker, but has the same effect. Topamax as well works by two mechanisms. So it is a carbonic anhydrase inhibitor, just like acetazolamide, but it also actually is a appetite suppressant as well, so potentially can work by a secondary mechanism. Furosemide as well, and nutrition and weight loss strategies are central to a lot of these patients because of the elevated BMI. I'm going to briefly touch upon a study where a randomized control trial where they did bariatric surgery for these patients. Optic nerve sheath fenestration is an option, especially in emergencies where there's loss of vision, and especially for patients who have unilateral papilledema. Optic nerve sheath fenestration is oftentimes the first go-to. And then venous sinus stenting has really become actually one of the major ways that we treat this now. So in the past, it was mainly, we would put in ventriculoperitoneal or lumbar peritoneal shunts. Now, actually, we go straight to venous sinus stenting if there's evidence of transverse venous sinus stenosis. We do that first before considering a shunt. So when it comes to venous sinus stenting, we're starting to learn a lot more about it. There's a lot of clinical, randomized control trials going on right now. We don't actually have that data yet, but hopefully we will have that data in about a year or 2 years. So the complication rate's pretty low. It's only in the range of about 2%. In general, now one thing that makes it very variable between centers is that different neurosurgeons or interventionists are going to decide to put a stent in based on different pressures. So for example, in some centers, they might say, okay, well, there's a change in pressure, a drop in pressure of about 5, so I'm going to put a stent in. Other centers are a little bit more stringent. They'll use 8 to 10 millimeters of mercury as a cutoff in order to figure out whether or not somebody's a candidate for a stent. So because of that means that a lot of the data that comes out of that is this is going to be a little bit inconsistent. Some of the biggest issues is possible restenosis adjacent to the actual area of the stent. And that actually, in some series, has been shown to be as high as close to 20%. The other drawback is the fact that you need to have patients on antiplatelets, dual antiplatelets for a period of time. Again, the length of time is going to depend on the neurosurgeon. And generally, patients will then afterwards will often have to continue with aspirin. A more recent study, actually, that was published in March, however, and I'm going to touch upon this point later because it's really important, is that a lot of these patients, in terms of their visual symptoms, improve substantially. So if we're looking at, parametric mean deviations for visual fields, or we're looking at papilledema and ICP, all those things get better. But what doesn't get better, unfortunately, are a lot of the symptoms, and especially the headaches. In fact, in the majority of patients, the headaches will not get better. And that is part of the reason why a lot of the time we don't do any intervention unless there is some degree of visual loss, because that's what we're trying to save. So this is just an example. I'm not going to go through every one, but this is an example of the ongoing clinical trials for venous sinus stenting. All over the world. There's a UK trial, there's a China trial, there's a couple trials going on here in the USA. These should all be completed 2025, 2027. Hopefully we'll get some data on this. So we'll have a little bit more information. And then this was kind of the seminal trial. This is the real trial that started as acetazolamide or Diamox as the main treatment for IH. And so this was actually started back in 2010. And so this was a multi-center trial. There was 165 patients in total. And this basically showed, starting at actually a pretty high dose of Diamox, patients would be started on 250 milligrams twice a day, increased weekly up to 4 grams a day, and actually showed statistically significant improvements in visual symptoms. And so now the go-to treatment is to start patients on acetazolamide if they do come in with high intracranial pressures, and we are concerned about IH. So again, looking at the outcomes of this trial, you can see at the bottom here that ICP went down quite significantly. Again, here this is looking at a freezing grade, which is looking at papilledema and how the papilledema has changed. So papilledema was significantly improved, and this is over the course of 6 months. And same thing here, this was their primary outcome measure, and this was looking at visual fields, and the visual fields as well improved quite substantially over the course of 6 months of treatment. So this goes through the specifics of the trial. Again, the important point to mention is that even in this trial at month 6, majority of participants found that they continued to have headaches. So when they looked at the HIT-6 score, and that's basically called the headache impact test, and it determines the effect of headache on quality of life, that those scores did not significantly change. Now, it sounds great, we can give Diamox to everybody, but unfortunately, Diamox has a lot of side effects. And you can actually see this here. So this is looking at all the adverse events by treatment group from this trial. And you can see that approximately 47%, almost 50% of patients had pretty significant paresthesias, the very common complaint with Diamox. Other things are nausea, fatigue, headache. That's in a very, very good proportion of patients. So if you actually look at the numbers, approximately 50% of patients will stop taking this drug because of side effects. And so that's really important. So this is not the best medication to use long-term for a lot of these patients. And so there was one trial that was done looking at the efficacy of bariatric surgery versus a community weight management plan. And this trial had only 66 patients, but actually showed in terms of intracranial pressure, there was a significant drop in intracranial pressure when patients lost approximately 20% of their weight. And you can see these improvements here. Now, interestingly, in this particular trial, they did not see a change, at least statistically significant. There was a trend in improvement in these visual symptoms, but it wasn't statistically significant. So again, as I mentioned, one of the kind of core principles of treating IH patients, in addition to the acetazolamide, is a nutrition plan and weight loss. And so the question is, well, why does weight reduction actually cause a decrease in ICP? And the thought of that is that just in general, if you decrease intra-abdominal pressure, intrathoracic pressure, that decreases central venous pressure and allows more of the CSF to flow out of the brain and therefore decreases the pressure in the brain. The other possibility is that, as people know, obesity is known to be associated with kind of a low-grade chronic inflammatory state, and that also could potentially contribute to elevated pressures. So I'm sure everybody's heard of Ozempic by now. I think over the past year it has become kind of like one of the most common medications. But it raises the question, can these medications, these GLP-1 agonists, actually be effective for patients with idiopathic intracranial hypertension? So these medications are fairly well tolerated, especially compared to things like Diamox. And they work by multiple mechanisms. So actually work on the hypothalamus to increase satiety, increases insulin secretion and decreases insulin resistance, and also decreases gastric emptying. So the main complaint of patients taking this drug is that they feel nauseated or they can't eat as much, and that's most likely due to the effect on gastric emptying. And so there was actually in 2023, this was published, and this was a randomized controlled trial with a very small number of patients, only 15 patients in this trial. But they actually showed that just looking at intracranial pressure was statistically significantly dropped, even after a couple hours of treating patients with exenatide with one of these GLP-1 receptor agonists. So why is that the case? So this is actually an interesting slide. So what this is these are basically the cells that produce cerebrospinal fluid in the brain. And so the tissue that we think is responsible for producing most of the cerebrospinal fluid is going to be the choroid plexus. And the choroid plexus kind of sits in the lateral ventricles and the other parts of the ventricles and the fluid spaces of the brain. And so if we look at the cells, the epithelial cells that make up part of that choroid plexus, this is where a lot of these drugs actually work. And so you can see carbonic anhydrase here. So topiramate, acetazolamide both affect carbonic anhydrase. What is interesting, furosemide obviously has an effect on the NKCC receptor. What's interesting is that the GLP-1 receptor agonists, there's actually receptors for these drugs on the choroid plexus epithelial cells. And so it's thought that these drugs also potentially can reduce intracranial pressure by actually inhibiting the sodium-potassium ATPase. What that does is there's this water channel called aquaporin-1, which is in all the choroid plexus cells. And what that causes, that water channel, once that sodium-potassium ATPase is activated, basically water is kind of pumped into the ventricles. And so if we reduce that effect and we reduce the effect of aquaporin-1, we can actually reduce the amount of CSF that's produced. And so the thought is that this GLP-1 agonist, in addition to causing weight loss and potentially reducing ICP that way, that this drug can actually act directly on the choroid plexus epithelial cells to reduce ICP. And so we are actually currently in the final stages of the protocol putting this together. Hopefully it will be approved and can actually start this trial pretty soon, but we're doing this at Duke. So we're doing it with it's an investigator-initiated trial with tirzepatide, which is the Eli Lilly version, which is slightly a little bit more effective than Ozempic in terms of weight loss. And so this just shows the inclusion criteria that we're using for these patients. So we're actually, unlike most trials, we're actually enrolling patients who have either unilateral or bilateral papilledema. BMI has to be greater than 30. And this is the basic modified Dandy criteria for IH. Ooh. There we go. So we're going to be enrolling 60 patients and hoping to get most of that enrollment over the course of 12 months. So we're going to be following patients over the course of 12 months. Everybody's going to undergo a targeted weight management program in addition to either placebo or tirzepatide. It's going to be double-blinded. Our primary outcome measure is going to be intracranial pressure. And then our secondary outcome measures are going to be similar to a lot of these other studies. So we're going to be looking at papilledema. Neuro-ophthalmology is heavily involved. We're going to be doing fundus photography, OCT, looking at mean headache days, looking at quality of life factors, and also seeing whether or not this has any effect on headache. So just to conclude, my talk today, patients who come in with Chiari, sometimes one has to think about the possibility that the Chiari could be acquired and could be secondary to IH, as it's actually quite common for IH patients to have tonsillar ectopia and also to have headaches and clinical symptoms that mimic the typical headaches and clinical symptoms of Chiari malformations. So I talked a little bit about how to differentiate those two. I think that if there's, from my standpoint, if there's any signs or I get any sense that a patient might have high intracranial pressure, I think it's pretty, low risk to do a lumbar puncture, and we can just get a direct pressure that way. Again, the reason it's important is because we don't want to do posterior fossa decompressions on patients who actually don't need them or are going to get worse from the surgeries. And the treatment for IH most of the time is medical, so we can just give people medications and they actually improve. And only under the situation where, conservative therapies have been exhausted, in those situations we would generally consider surgical intervention. And so right now I think that we're at a really good point because there's a lot of clinical trials going on. We have some promising preliminary data, and hopefully we'll have other ways of actually treating this effectively in the near future. So, all right. Thank you very much.